Good afternoon or good morning, everyone, depending on where you are. Thank you for joining Debbie Stream Foundation's webinar series. Today's webinar features Dr. David Ilson, who will give a presentation on clinical trials updates for gastric cancer patients. I am Jen Higgins-Spires, Programs Manager for Debbie Stream Foundation, and I will be moderating the webinar today. Thank you to our generous sponsors for making today's program possible. Platinum sponsors Bristol Myers Squibb, Merck, and Taiho Oncology. Bronze sponsor Arcus Biosciences. Silver sponsor Amgen. And copper sponsor Lilly Oncology. First, I will share information about stomach cancer and Debbie Stream Foundation, and then we will hear a presentation on clinical trials updates for gastric cancer patients from Dr. David Ilson, and the Q&A session will follow the presentation. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate of between 20 and 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Debbie Stream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiestream.org. Picture here is Debbie Zellman, the founder of Debbie Stream Foundation. Debbie was diagnosed with stage 4 cancer in April of 2018. She had no risk factors and only vague symptoms. By the time she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017 at the age of 50 after a 9.5-year battle with stomach cancer. As an organization, Debbie Stream continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the United States, including Canada. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided more than $1.5 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Earlier this year in March, we traveled to Washington, D.C. with more than 150 advocates, held over 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout yet. We hope that you'll join us next year to let Congress know that we need a cure. You can type your questions throughout the presentation into the chat section or question section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. Before we begin, I'm delighted to introduce our speaker. David Ilson is an attending physician and member at Memorial Sloan Kettering Hospital in New York and a professor of medicine at Weill Cornell Medical College. He is a nationally recognized authority in the treatment of gastrointestinal cancer, whose primary area of research involves upper gastrointestinal cancer with a specific focus on esophageal cancer. Much of his research has focused on the study of new agents in advanced esophageal cancer and the evaluation of novel agents in the combined modality therapy programs in locally advanced disease. Dr. Ilson's other areas of clinical expertise includes gastric, colorectal, esophageal, pancreatic, and other gastrointestinal cancers. We will now begin the presentation on clinical trials updates by Dr. David Ilson.
Great, thanks very much for the generous introduction. I just need to see where I can forward the slides here. Okay. Yeah, is there a marker to forward the slides? I don't see. Or do I just click on them?
You should be able to click on them, or on the left side of the screen, you should be able to see the little arrows.
I see it. I got it.
Yeah.
I got it. Okay. Except that disappeared. All right. So it's my pleasure to review today advances in immunotherapy and targeted agents in gastroesophageal cancer. Yeah, those arrows disappeared. I don't see them on my screen. I'm sorry.
I can advance for you. Just let me know.
Okay, next slide. These are my disclosures, which are largely consultancies with various pharmaceutical companies. Next slide. So in the course of my talk today, I'm going to review advances in immunotherapy and targeted agents in esophagogastric cancer. We'll talk about how immunotherapy has moved to first-line treatment in gastric cancer. And we'll also talk about the potential use of immunotherapy treatments after surgery and local therapies in esophageal and GE junction cancers. I'm going to talk a little bit about novel and enhanced HER2-targeted therapy and other new emerging targets, which include Claudin and FGFR. Next slide. So I just wanted to overview for the audience what different phases of clinical trials represent. One of the most common is the phase 3 trial setting, and that's where we're comparing a standard of care therapy to a new treatment. In some cases, the standard of care treatment may be no treatment, and that's the case in which placebo is included in the trial, no treatment. Some phase 3 trials modify standard therapy, or other phase 3 trials either add new agents to standard treatment or pilot new agents altogether. In phase 2 trials, pretty much everybody gets the novel therapy, so it's a single-arm study. And the main goal of a phase 2 trial is to see if there's activity or responses to a new therapy. Some of these trials are randomized, so that is, we're assigning patients to potentially 2 similar novel treatments. Phase 1 trials are the early phase of drug development. Here we're studying a new therapy altogether or a new combination. Because it's a new drug or a new therapy, the main goal is to establish that it's safe to give and establish side effects. But oftentimes in phase 1 trials, the actual effectiveness of the treatment is not the primary goal, even though there may be promise from earlier laboratory investigation of such new drugs. It's important to understand that in 2024, clinical trials are largely directed to patients with specific biomarkers in their cancer. So that is, we study the cancer to see if there are specific targets for new drugs that may enhance the benefit that patients may receive from new therapies. Next slide. So I just want to talk a little bit about the surgical setting, patients that have operable gastric cancer. We know that adding chemotherapy to surgery improves survival in gastric cancer. In the United States and the West, the standard approach is to administer chemotherapy before and after surgery. And the standard chemotherapy is a regimen called FLOT, which is 5-FU, oxaliplatin, and taxotere. However, in Asia, countries like Japan, Korea, and China, it's very standard to do surgery first and then to give chemotherapy after surgery. And typically it's 6 months of treatment, often using a combination of the drugs capecitabine and oxaliplatin. The older use in the United States of surgery followed by radiation and chemotherapy is much less used now. The preferred approach is surgery alone and to administer either chemotherapy before and after surgery or to do surgery and administer just chemotherapy after surgery. Next slide. So there have been recent studies evaluating the role of whether adding radiation to surgery and chemotherapy adds any benefit. And these studies are consistently reading negative. So there was recently at the European Cancer meeting in Barcelona last month, a presentation of a global trial called Top Gear. And this trial asked the question, should we give radiation therapy to patients getting preoperative chemotherapy in gastric cancer? So this was a randomized trial in which everybody got preoperative and postoperative chemotherapy, except half of the patients also got radiation combined with chemotherapy before surgery. This trial treated over 570 patients. Most of the patients, more than half, had gastric primary cancers. And you can see that most had locally advanced cancers. So there was evidence of lymph node involvement in 62%, and the tumor going through the wall of the stomach in about 90%. This trial allowed either chemotherapy with FLOT, which is the standard, or the older standard perioperative chemotherapy, ECF. Next slide. And we can see this trial showed no survival benefit for the addition of radiation. So it's becoming increasingly apparent in treating gastric cancer and esophageal adenocarcinomas that chemotherapy alone should be the standard of care, and adding radiation does not add benefit. Next slide. So what about the use of immunotherapy? We're going to talk about that later because we know that combining immunotherapy with chemotherapy in stage 4 or metastatic gastric cancer improves outcomes. Does immunotherapy added to surgical management add any benefit? I'd have to say, unfortunately, to date, the trials adding immunotherapy to surgery and chemotherapy have not shown an improvement in survival. There was a key trial from Japan. Here, patients got initial surgery followed by chemotherapy, and adding a year of nivolumab immunotherapy treatment to surgery and chemotherapy did not improve outcome. Recently, a trial done in the West, Keynote 585, added pembrolizumab, another immunotherapy drug, to perioperative chemotherapy. This did improve the response to chemotherapy. So more patients responded to preoperative treatment, but at the end of the day, there was no improvement in survival. The last trial that we're waiting for is a trial called Matterhorn. This is adding durvalumab, another immunotherapy drug, to preoperative FLOT. This trial also showed improvements in response at surgery, but we don't have any results about whether this drug improves survival. Next slide. There is, however, a role for immunotherapy in patients with esophageal adenocarcinoma if patients undergo the older approach of chemotherapy and radiation. So remember, I told you that radiation is falling out of favor, but in the past, particularly for esophageal cancer, we would combine chemotherapy, radiation, and surgery. Checkmate 577 was a trial in which patients with esophageal adenocarcinoma underwent chemotherapy, radiation, and surgery, and the trial assigned patients to get a year of nivolumab as preventive treatment. Next slide. So this trial did improve disease-free survival. So in the setting of esophageal cancer, adenocarcinoma, in which patients get chemotherapy, radiation, and surgery, there is a benefit for adjuvant nivolumab after surgery, and this is right now the only approved indication for combining immunotherapy with surgical management. Next slide. So I want to comment a little bit about MSI-high gastric cancers. This is a very important subset, and all patients with gastric cancer need to have their tumor tested for MSI status. The other name for this is called mismatch repair protein deficiency. It's very easy to stain the tissue for this. MSI-high or mismatch repair protein deficient gastric cancers tend to behave better, and they also respond better to immunotherapy. So this was a pooled analysis globally looking at patients with locally advanced gastric cancer that underwent surgery, so localized gastric cancer undergoing surgery. And on this slide, we can see survival curves. So the blue curves are the patients that had MSI-high gastric cancers. So you can see that both disease-free and overall survival were markedly superior in patients that had MSI-high localized gastric cancers compared to microsatellite stable or mismatch repair protein proficient gastric cancers. Next slide. So why else is this important? So in addition to patients with MSI-high localized gastric cancers having better survival with surgery alone, if you look at the right-hand panel here, as I told you earlier, the standard approach for gastric cancer is to combine chemotherapy with surgery. That improves survival. However, if you have an MSI-high cancer, look at that panel on the right. Those top two curves that I've circled there, the green curve is the patient with MSI-high gastric cancers that just had surgery. They didn't get any chemotherapy. The yellow-orange curve right underneath is the patients with MSI-high gastric cancers that got surgery and chemotherapy. So you can see they actually did worse than if they just got surgery alone. So this is why it's important when we're considering surgery for gastric cancer to know whether they're MSI-high or microsatellite stable. Number one, patients with MSI-high gastric cancers may have a better prognosis with surgery alone, and MSI-high gastric cancers may not benefit from conventional chemotherapy. They may just require surgery without other treatment. Next slide. Now, there have been studies because we know that MSI-high gastric cancers respond very, very well to immunotherapy. So this was a trial from France where they focused specifically on MSI-high or mismatch repair protein deficient gastric cancers that were going to undergo surgery. And rather than give them chemotherapy or radiation, they gave them 3 months of immunotherapy. So they gave them 3 months of immunotherapy followed by planned surgery. And the immunotherapy was a combination of the drugs ipilimumab and nivolumab. Next slide. So in the 32 patients treated on this trial, 29 went to surgery. And if you look in the upper right-hand corner, TRG1 means that the surgeon found no cancer at surgery. So they were a complete remission to immunotherapy. That was seen in 60% of patients. TRG2 was a near complete response. That was observed in nearly 15% of patients. So 75% of patients with MSI-high gastric cancer, if they got immunotherapy before surgery, they had significant responses, complete responses. So the other issue, if we go on the next slide. So how did these patients do after surgery? So the left-hand curve is disease-free survival. It's nearly 100%. And the right-hand curve is overall survival. So the survival was nearly 100%. So this is a lot better than what we do with surgery alone or chemotherapy added to surgery. So we will increasingly have discussions with patients with MSI-high gastric cancers. Should you get surgery alone? Should we consider immunotherapy added to surgical management? So this is a research question that we're studying and is ongoing. But it's important that we know if you have a localized gastric cancer, whether you're MSI high or not. As I'll show you later, it's also important to know when you have stage 4 metastatic gastric cancer, if you're MSI high or not. Next slide. So let's talk a little bit about chemotherapy before we talk about targeted agents. So the NCCN National Guidelines Panel endorses 2-drug chemotherapy to treat stage 4 gastric cancer. So typically that would be the regimen FOLFOX or oral capecitabine plus oxaliplatin, and we also endorse the regimen FOLFIRI. We typically do not recommend 3-drug chemotherapy regimens, so that would add the drug docetaxel to platinum 5-FU. It's much more toxic. And there have been a number of clinical trials, not only in Europe, but in Japan, that have not shown better survival for patients getting 3 chemotherapy drugs over 2 chemotherapy drugs. So what about currently available targeted agents? So if you have a HER2-positive metastatic gastric cancer, it is now standard to add Herceptin or trastuzumab to first-line chemotherapy. And as I will show you later, we now also add immunotherapy. So if you're HER2 positive, you should get chemotherapy, trastuzumab or Herceptin, and pembrolizumab as part of first-line treatment. The benefit, as we'll see, is really limited to patients that are PD-L1 positive. You have to test PD-L1 positive. So the other application of immunotherapy is everybody else. So nivolumab, the immunotherapy drug, is approved to combine with first-line chemotherapy in metastatic gastric cancer. Right now, the cutoff for PD-L1 positivity is 5%. That may be lowered to 1%. And also, pembrolizumab is approved to combine with first-line chemotherapy, usually FOLFOX, in metastatic gastric cancer. Some of the guidelines set the PD-L1 positive cutoff at 10%. Recent studies suggest 1%. I suspect that the guidelines are going to be harmonized pretty much to allow anybody to get immunotherapy added to chemotherapy as long as the PD-L1 CPS is 1% or higher. That accounts for about 60 to 70% of patients. Next slide. So what about second-line chemotherapy? After FOLFOX and nivolumab or FOLFOX and pembrolizumab, it is standard of care to add an angiogenesis drug to second-line chemotherapy. That drug is ramucirumab, which targets the receptor VEGFR2. In the second panel, I've highlighted that the standard of care second line is paclitaxel plus ramucirumab. This was shown to be superior to paclitaxel alone in second line treatment from the Rainbow trial. Next slide. Now, the other regimen that's approved to combine with ramucirumab as a second line treatment is FOLFIRI, because many patients have gotten docetaxel or paclitaxel as their surgical treatment. Remember, I told you FLOT, 5-FU oxaliplatin, Taxotere, that's the standard preoperative chemotherapy. So many patients have had previous exposure to Taxol-like drugs, and maybe they won't benefit if they have recurrence, and we try and give Taxol again. So there was a study done from Germany, which looked at patients and second-line treatment, and they actually compared the combination of FOLFIRI plus ramucirumab versus Taxol, paclitaxel plus ramucirumab. And if you look at the survival curves in the upper hand right, you can see for overall and progression-free survival that FOLFIRI and ramucirumab and Taxol ramucirumab were equivalent. There may be a suggestion, however, if you had gotten prior exposure to a taxane, like with the FLOT regimen, that FOLFIRI might have resulted in better response and more time on treatment. So if patients have recently gotten exposure to Taxotere or a taxane, we would probably prefer FOLFIRI ramucirumab over Taxol ramucirumab as the secondary treatment. Next slide. So what do we have to test for in a newly diagnosed metastatic gastric cancer? It always surprises me that some pathologists are still not running these tests. These 3 tests are mandatory. So the 3 tests in a newly diagnosed metastatic gastric cancer, we have to test for HER2. So you need to do HER2 testing. You need to do that MSI high or mismatch repair protein testing, and you need to test for PD-L1. Those are the 3 obligatory tests. If you're HER2 positive, you get Herceptin. If you turn out to be MSI high or mismatch repair protein deficient, that predicts an excellent response to immunotherapy drugs. And then if you're PD-L1 positive, you should also get immunotherapy combined with chemotherapy. Now, what are the new biomarkers? Claudin is an emerging new biomarker. That's a protein in gastric cancer, Claudin 18.2. We'll talk about that later, but that marker will also probably need to be tested initially because we're about to see approval for a new drug that targets the Claudin pathway. Another promising pathway is FGFR that we'll talk about later. So what about genomic profiling of the cancer, taking the tissue and looking at hundreds of genes and mutations? That's called next-generation sequencing. That is now standard practice for patients with newly diagnosed metastatic gastric cancer. So in addition to doing the standard biomarker tests, HER2, mismatch repair proteins, and PD-L1, we should now do next-generation sequencing. So why should we do this? Well, it will study the cancer for HER2 and other genes that are amplified. It will test for other rare and targetable gene mutations. I've listed a few here. And if we don't have enough tissue from your biopsy, your physician can send a blood sample to do blood-based genomic profiling. That's perfectly acceptable. And pretty much everyone now with stage 4 metastatic gastric cancer, as part of their initial workup, in addition to standard immunohistochemistry tissue testing, we talked about HER2, mismatch repair proteins, PD-L1, claudin, patients should also have next-generation sequencing, either with tissue-based or blood-based testing. Next slide. So what have we learned from genomic profiling of gastric cancer? There are actually 4 unique genomic subsets in gastric cancer. The most common is what's called genomically unstable gastric cancer. That's about 60% of patients. These are the patients that have HER2 amplification and also amplification of other such pathways. MSI high, remember I told you that's an important subset where immunotherapy is a home run, very active. That's about 7 to 8% of gastric cancers. And you could actually argue, and I'll show you data later, that immunotherapy by itself is better than chemotherapy to treat these patients with metastatic MSI high gastric cancers. There are 2 other subsets, genomically stable and Epstein-Barr virus positive cancers that have less clear treatment implications. Next slide. So I'm going to spend the next part of the talk reviewing the recent studies for immunotherapy. So the 2 pathways for which we have drugs either approved or in development are the CTLA-4 pathway and the PD-1 pathway. If you block those pathways, what you do is you overcome immune suppression in the cancer. So if you block these pathways, it allows your immune system to respond to and fight back the cancer. And we have drugs targeting CTLA-4 like ipilimumab. We have drugs targeting PD-1, which include nivolumab and pembrolizumab. Next slide. So I'm not going to have time to discuss all the studies. So in the highlighted yellow studies below, these are all the positive trials for combining immunotherapy with first-line chemotherapy in esophagogastric cancer. Keynote 590 showed that adding pembrolizumab to capecitabine oxaliplatin improved survival in patients with gastric cancer and esophageal cancer. Actually, this was pembrolizumab plus 5-FU platinum. Keynote 859 was another positive trial for pembrolizumab added to capecitabine oxaliplatin in metastatic gastric and GE junction cancers. Checkmate 649 was the positive trial for nivolumab added to FOLFOX in first-line metastatic gastric cancer. And Keynote 811 was the HER2 positive trial showing a benefit for adding pembrolizumab to chemotherapy plus Herceptin or trastuzumab in first-line treatment. Now, initially, the US FDA did approve use of these drugs for everybody, regardless of their PD-L1 status. But as I'll show you, it's pretty evident that if you're PD-L1 negative, if your score is 0, you probably don't benefit from immunotherapy. Your score has to at least be 1% or 5% or higher. Next slide. Now, before I talk about the data for immunotherapy in advanced gastric cancer, I want to focus on this one trial, Keynote 62. This was a negative trial of pembrolizumab, but the unique thing about this trial is they studied a significant number of patients that had MSI high cancers, and they compared pembrolizumab alone, so immunotherapy alone, immunotherapy plus chemotherapy, or chemotherapy alone. Next slide. So here we observe that if we compare pembrolizumab versus chemo in MSI high gastric cancers, you can see that obviously survival is dramatically better for patients that are MSI high positive if you get pembro compared to chemotherapy. So this really indicates it's mandatory. If you have metastatic stage 4 gastric cancer that's MSI high, you need to get immunotherapy. And this trial clearly showed pembrolizumab was superior to chemotherapy. In fact, the average survival time with pembro, it wasn't even reached. Patients were doing really well more than 2 or 3 years into treatment. So what about adding chemo to pembro in MSI high cancers? Not clear if it added any benefit. This outcome looks very similar to pembro alone. But the point is that pembro, with or without chemo in an MSI high gastric cancer, was superior to chemo alone. So these patients have to get immunotherapy alone, maybe combined with chemotherapy in first-line treatment. Next slide. So these are all the positive trials for pembrolizumab and nivolumab. improving survival in first-line treatment in metastatic gastric cancer. So you see the survival curves. All of the superior survival outcomes were achieved when patients got immunotherapy. Next slide. The benefit, however, so this slide looks, now these are called forest plots. So anything to the left of the center line indicates a benefit. Anything that overlaps the center line indicates no benefit. So you can see that for Keynote 590, a survival benefit was only seen in patients that were PD-L1 10% or higher. For nivolumab, a survival benefit was only seen if your PD-L1 was 5% or higher. For Keynote 859, the cutoff was 1%. And you can see in that third curve, if you're PD-L1 negative, there was no survival benefit for Pembro, but if you were greater than 1%, there was a survival benefit. And for Keynote 811, again, you had to be a PD-L1 1% or higher. If you look, you see if you're PD-L1 negative, there was no difference for adding pembrolizumab to chemo compared to chemo and Herceptin alone. Next slide. So I'm not going to go into all these studies, but the Chinese have a lot of these drugs in development that are yielding similar benefits in gastric cancer. These include sintilimab, toripalimab, and tislelizumab. So these are competitive drugs being developed in China for gastric cancer that get very similar outcomes to the Pembro and Nivo that's available in the United States. Next slide. So what's the future of immunotherapy? So we're very interested in cell-based immunotherapy, including technology like CAR T cells. CAR T cells take T cells from the patient, and then they engineer the T cells to attack the cancer, to attack a specific antigen in the cancer. So these CAR T cells are engineered from each patient, and they target specific antigens in the cancer. And pathways in development include HER2 and Claudin, which I'll talk about later. And I will review some recent provocative data for CAR T cell therapy in Claudin. Now, some of these are highly restrictive trials. You have to have a certain HLA subtype in your makeup, and they have very strict eligibility criteria. Another exciting area of drug development, we know that immunotherapy drugs, which are monoclonal antibodies, a lot of these new drugs are monoclonal antibodies that block pathways. Now we're looking at novel antibody constructs, so actually constructing new antibodies in the laboratory. Some of these novelly constructed antibodies, part of the antibody targets an antigen like Claudin or HER2, and another part of the antibody helps recruit immune cells. So this is a very exciting area of drug development. And obviously, there's a lot of interest in combining these new drugs with existing therapies. Next slide. So HER2 is not in esophagus and gastric cancer is not the same as breast cancer. So to date, we have only one drug first line approved for HER2 positive gastric cancer. That's Herceptin or trastuzumab. And you can see in the right and the upper right that survival was better in patients with HER2 positive gastric cancer when they got trastuzumab, Herceptin added to chemotherapy compared to chemotherapy alone. Drugs that didn't work that work in breast cancer include lapatinib and pertuzumab. They added no benefit. Next slide. So now the standard of care, in addition to chemotherapy plus Herceptin, is to add pembrolizumab as well. So this was the subject of Keynote 811, adding pembrolizumab to first-line chemotherapy with trastuzumab or Herceptin. So this was a randomized trial, and you can see in the upper right that, remember I told you PD-L1 positive is important. 85% were PD-L1 positive, and 80% were strongly positive for HER2. Next slide. So the first analysis of this trial looked at the first 260 patients. Now, if you look at those curves there, on the left, the green bars, those are all the patients that responded to treatment. If you look at the right, those are in the red bars, those are the patients that responded to chemotherapy alone. And you can see, obviously, that the response was dramatically improved when pembrolizumab was added to chemotherapy plus Herceptin. In fact, the response went from 52% to 75%, unprecedented. So the FDA actually gave tentative approval based on these initial reports for combining pembrolizumab with chemotherapy and trastuzumab in the first-line treatment of HER2-positive gastric cancer. Next slide. Next slide. So recently, the survival data were reported for KEYNOTE-811, and you can see superior survival. So that upper curve in the graph represents better survival for pembro plus chemo compared to chemo alone. And the improvement in survival was almost 3.5 months. So pembrolizumab improved survival added to chemotherapy in HER2-positive patients. Next slide. So this looks at the PD-L1 positive subset. So this was the 85% that were PD-L1 positive, 1% or higher. So we saw overall survival improvements, progression-free survival improvements. And again, if you look in the right hand, again, this dramatic improvement in response from about 56% to 73% with the addition of pembro. Next slide. Now, however, PD-L1 negative patients. So look at the upper right-hand corner. These were patients that had PD-L1 negative cancers. So you can see that the time to progression on treatment was no different, 9.5 months, whether or not patients got pembro, and there was no improvement in overall survival. So in fact, you could argue the patients that got pembro had a slightly inferior survival. So we really limit the use of pembrolizumab in HER2-positive gastric cancer to patients that are PD-L1 positive, 1% or higher. Next slide. So what about second-line treatment? What do you do after your tumor grows on first-line Herceptin, chemo, and pembrolizumab? So breast cancer drugs didn't work in this situation. TDM1, which is a breast cancer drug, was no better than chemo alone. What about continuing the Herceptin? We do this in breast cancer all the time. You start with Herceptin, you keep giving it second, third-line treatment. That didn't work in gastric cancer. And also lapatinib added to Taxol was no better than Taxol alone. Next slide. So the landscape changed with the approval of trastuzumab deruxtecan, or Enhertu. This is a second-line drug. I'll talk about trastuzumab deruxtecan in a minute. It's an antibody drug conjugate. This drug got approved globally based on a randomized trial that compared trastuzumab deruxtecan to chemotherapy alone as second-line treatment in HER2-positive disease. The other drug I'm going to talk about, which is on the horizon, is zanidatamab. That's an exciting new antibody that is in ongoing first-line development. Next slide. So trastuzumab deruxtecan, this takes trastuzumab, which is a monoclonal antibody, so it's Herceptin, but they tag onto it a chemotherapy drug. So it delivers the chemotherapy drug to the cancer cell via an antibody. The chemotherapy payload is called exatecan. Next slide. So Destiny-01 was a randomized trial conducted in Japan and Korea in which patients had gotten prior chemotherapy plus Herceptin. Their cancer grew. So as a secondary treatment, patients received either standard chemotherapy, which was either paclitaxel or irinotecan, or this new drug, trastuzumab deruxtecan. It's a randomized trial. Next slide. So here you can see in the upper curve that trastuzumab deruxtecan achieved responses in 42% of patients compared to only 13% of patients getting chemotherapy. And in the right-hand curves, we can see that both overall survival and time on treatment was substantially better. So based on this, this is the new standard of care for second or later line treatment in HER2-positive patients. There is a warning, however, lung inflammation develops in about 10% of patients. So the oncologist has to monitor patients very carefully. If lung inflammation or pneumonitis develops, the drug has to be treated and the drug has to be stopped. Next slide. So a similar trial was done in the West. You know, remember the trial that got approval for this drug was only conducted in Japan. So we did a similar trial in the West, and in 80 patients receiving trastuzumab deruxtecan, you can see very similar response. About 40% and similar time on treatment and survival. So this Western trial just validated that we saw similar effectiveness for this drug in Western patients compared to Asian patients. Next slide. So there are ongoing trials of trastuzumab deruxtecan. I'm going to mention two. Remember I told you earlier that standard secondary chemotherapy is Taxol plus ramucirumab. So in HER2-positive patients, there is a trial comparing Taxol ramucirumab versus trastuzumab deruxtecan, which is the better treatment second line in HER2-positive patients. And then there's exciting data emerging for giving this trastuzumab deruxtecan as initial treatment in patients with HER2-positive disease, but I don't have time to comment on this early phase data. Next slide. So I want to talk about zanidatamab. You have to keep this drug on your radar. This is an engineered antibody like Herceptin. It's only an antibody, so it's not even chemotherapy. But zanidatamab attacks two places on the HER2 target. So it has two targets on HER2. And what's remarkable, usually Herceptin, like trastuzumab, Herceptin has no effectiveness at all by itself in gastric cancer. However, this drug, even by itself, has a 20 to 30% response in HER2-positive gastric cancer. So this is unprecedented in gastric cancer for an antibody alone without any chemotherapy component to have effectiveness. Next slide. So there was a global trial combining zanidatamab with chemotherapy in the first-line treatment of HER2-positive gastric cancer. So I want to call your attention to those blue bars in the upper left. That shows 75% of patients responded to this drug. The median time to maintaining this response was a year. So this is clearly an active combination, and there are two global trials looking at this combination in first-line treatment in HER2-positive patients, zanidatamab plus chemo, and then there also is a trial adding immunotherapy as well. So we anxiously await the results of zanidatamab first line. Is it going to turn out to be better than standard Herceptin? Next slide. So I just want to comment at the last few slides about other novel targets. FGFR is another receptor on cancers that can be blocked with monoclonal antibodies. Next slide. So bemarituzumab is a monoclonal antibody that blocks this pathway. And it's interesting that in a trial in gastric cancer, even by itself, this in an amplified cancer that had amplification of FGFR as a target, the drug had about an 18% response rate. So obviously, there was a lot of interest to combine this drug with chemotherapy. Next slide. So the FIGHT trial, which was recently published, was a randomized trial of standard FOLFOX with or without bemarituzumab, the FGFR antibody, and patients had to test positive for FGFR. They were screened by just tissue staining, immunohistochemistry. 30% were positive. So this is a big subset of gastric cancer. About 30% were FGFR positive by tissue testing. Next slide. So adding bemarituzumab and FGFR positive gastric cancer improved progression-free and overall survival. So this was a positive trial. Next slide. And there also was about a 10 to 15% improvement in response. So this drug now is in first-line randomized trial development. The important trial in the US is FOLFOX nivolumab with or without bemarituzumab in FGFR positive patients. So stay tuned. Next slide. So I want to spend a little time talking about zolbetuximab. This is a drug that has going to get imminently approved by the FDA probably next month. Zolbetuximab is another monoclonal antibody that attacks the protein Claudin 18.2. Claudin 18.2 is pretty much only expressed or seen in gastric cancers and in the stomach. So it's a very specific target for gastric cancers. This antibody binds to this target, and it may result in an immune response. It may recruit immune cells and lead to cancer cell death by stimulating an immune response. Next slide. So there are two clinical trials that were positive for improved survival, combining zolbetuximab with first-line chemotherapy. Patients on these trials had to test positive for claudin. They had to have at least 75% of cells positive. So this was a randomized trial of FOLFOX with or without zolbetuximab in patients' cancers who tested positive for claudin 18.2. Next slide. So again, you can see that progression-free survival this is time on treatment. So patients had better progression-free survival with zolbetuximab. Next slide. And an improvement in overall survival, which translated overall into a 25% improvement in overall survival. And you can see that that survival improvement was sustained beyond 3 years. Next slide. Responses to the two treatments were about the same, about 60%. Next slide. And the main side effect that was added is nausea and vomiting. So if we're going to use this drug in clinical practice, we have to be very aggressive with giving patients many different anti-nausea medications to prevent nausea during treatment. Next slide. So the second positive trial of this drug was the GLOW trial. This also combined zolbetuximab with first-line chemotherapy, but here the regimen was capecitabine oxaliplatin. Again, patients had to have 75% positive staining for claudin, and about 40% of patients that were screened on both of these studies tested positive. Next slide. So here you can see that progression-free survival was also improved on this trial with about a 30% reduction in the risk of progression compared to chemo alone. Next slide. And overall survival was improved, again, about a 25% reduction in the risk of early death. So this was, and you can see again, a sustained benefit beyond 2 years. So this drug improved survival as well. Next slide. Similar to the FOLFOX trial, there were similar responses, about 49 to 53%. Next slide. So this drug is about to be approved in the US for claudin-positive gastric cancer. So then the question arises, well, should I get Herceptin, should I get immunotherapy, or should I get claudin as part of my first-line treatment? We can answer that in the Q&A session. How are patients best served? If you're HER2 positive, you probably should get Herceptin plus an immunotherapy drug and chemo. If you're PD-L1 positive, you should probably get nivolumab or pembro plus first-line chemotherapy. If you're claudin positive, I would probably focus this drug on the patients that are PD-L1 negative, because remember, if you're PD-L1 negative, you're not going to benefit from immunotherapy. So we now have claudin. If you're positive, we have claudin as a target in those patients that are PD-L1 negative. So what are other exciting areas of drug development for claudin? This is clearly a viable target in gastric cancer. So there are a number of new drugs in development for this pathway. I've highlighted here the data for antibody drug conjugates. So again, this combines the claudin antibody with chemotherapy. So the claudin antibody delivers the chemotherapy directly to the cancer cell. So there are 3 trials of different antibodies. One, the chemo payload drug was exatecan. That's very similar to trastuzumab deruxtecan. 2 of the others used the chemo payload MMAE. That's similar to Taxol. The point I want to make is if you look at the response rates, the responses range between 20 to 40%. That's exciting. So this new drug, claudin antibody drug conjugate, has significant activity in patients, and there does appear to be effectiveness across a range of different rates of positivity for claudin expression. Again, some of these drugs are going to go to randomized trials comparing the antibody drug conjugate to standard chemotherapy. Next slide. The other thing I want to talk about is the data for claudin 18.2 CAR T cell therapy. Remember I told you that CAR T cells are, you take the T cells from the patient and you engineer them to attack the target in the cancer cell. So there was a very exciting trial conducted in China looking at CAR T cells that were engineered to attack Claudin. In this phase 1 and 2 trial, they looked at 59 patients with chemotherapy-resistant gastric cancer. After progressing on standard chemotherapy, they had development of their own CAR T cells and then treatment. So they saw that about 55% of patients responded. So you see that those blue bars on the left. So this is pretty exciting that in a cell-based immunotherapy can induce response. Now, the only sobering thing here is that the response only lasted about 5 to 6 months. So with an overall survival of about 9 months. So we do know in CAR T cells, let's say in lymphoma, that we actually cure a fairly large percentage of patients where they're in remission 3, 4, and 5 years out. This is an active treatment, but the benefit, unfortunately, is relatively short-lived. So I think it is an approach that's still being studied, and it's only available now in very limited clinical trials. And despite a very promising response, again, the duration of the response is rather short. Next slide. Okay, well, I've come to the end of my slide set. I hope I've informed you about the status of immunotherapy and novel targeted agents in gastric cancer. We have now advanced immunotherapy to the first-line treatment of advanced gastric cancer. We now combine pembrolizumab and nivolumab with first-line chemotherapy in advanced gastric cancer. However, you have to be PD-L1 positive. CPS PD-L1 should be 1% or higher to gain benefit from these drugs. HER2 remains one of the most exciting targets. In addition to first-line Herceptin and pembrolizumab, we now have approval of a second-line drug, trastuzumab deruxtecan, and I encourage you to stay tuned to follow the progress of zanidatamab. What about the adjuvant use of immunotherapy combined with surgery? Right now, immunotherapy combined with surgery is only approved for esophageal cancers who receive chemotherapy and radiation and surgery. There is no proven benefit yet in gastric cancer for combining immunotherapy with chemotherapy alone. And other emerging targets that are exciting, Zolbetuximab for Claudin that we're about to see approval, Biomarker for FGFR. So it's an exciting time in gastric cancer. We're making progress on all fronts, and it's certainly an encouraging time to be a GI medical oncologist involved in clinical research. I thank you for your attention, and hopefully we have time for some questions.
Ilson, thank you so much for sharing all of this with us today. This is a topic that's really on the top of minds for many of our patients who are undergoing clinical trials or are looking to see if they would like to participate in a clinical trial. So we received so far a few questions. I'll see if any more might come in, but some people wanted to know why the Claudin gene is so effective in drugs compared to other biomarkers.
Well, it's very specifically expressed in stomach cancers. And, we never know a target is useful until we test it, right? So Zolbetuximab specifically targets that protein, and it was engineered to enhance immune response. So we now have positive data that combining this drug with chemotherapy in first-line treatment improves improves time on treatment and survival. So we don't know whether a target is useful until we test it. And then the other promising target in development is FGFR. There are other pathways in earlier phase development I haven't had time to talk about, like TROP and the DKN01. But Zolbetuximab will get approved for first-line treatment because we see better survival in patients getting this drug with chemotherapy.
Great. Yeah, a lot of people have been very, very anxious about Zolbe coming out, and so fingers crossed that no other things get in the way for that. And
it's already approved in Europe and Japan, so I think it's I think the date for the reapproval is going to be in November, and I anticipate it should move forward.
That's so great. If all the biomarkers are negative, are there any other options
Well, I think if you're HER2 negative, you shouldn't get Herceptin. If you're PD-L1 negative, sometimes insurers will cover nivolumab or pembrolizumab, but the likelihood you're going to benefit is very low. If you're Claudin negative, it's not clear if you benefit from Claudin drugs. So then you need to look at some of the other biomarkers like FGFR. That pathway is being studied. TROP1 is another target in development, and DKN01, which is another immune pathway. So I think the answer would be to pursue a clinical trial that is geared towards targeting your cancer.
Another question that came in, have you seen a difference in response to clinical trials if the tumor is an adenocarcinoma or if the tumor is a diffuse?
I think intestinal type cancers tend to do better overall, but signet ring or diffuse cancers respond to all of these drugs. So I can't say there's a differential benefit. There was some hope that zolbetuximab might behave better in diffuse cancers, but it looks about the same. So diffuse versus intestinal should not determine which treatment you get. You should get a targeted therapy or immunotherapy if it's appropriate.
Great, thank you. All right, so I was recently diagnosed, so they are looking at clinical trials for me, and one fear I have is having an adverse event happen to me during this trial, and if I do have a poor event, does this make me ineligible for all other clinical trials down the line?
No, well, remember, when you're a patient going on a clinical trial, you're the patient. If you have unacceptable side effects, you can stop a treatment at any time. So anytime we introduce a new drug, there's a risk of different side effects. But then the flip side is if you're getting a new drug, maybe you'll get something that's more effective. So the answer is no. If you have an adverse event, we deal with it and we support you and we monitor you and we hopefully can continue the treatment. The exception would be if you had a severe immune-related adverse event that might exclude you from future immunotherapy trials. But adverse events with treatment don't necessarily exclude you from either ongoing treatment or access to new therapies. So, we encourage people to go on clinical trials if they're getting standard treatment plus something that's new and promising.
And another question that had come in was about the feasibility of getting to a clinical trial if they have to travel for it. Are there grants to help patients pay for?
Some trials do provide some support, but then it gets to be a quality of life issue as well. If you're traveling a long distance to get a new treatment, you got to balance it against your quality of life. I think that needs to be individualized for each trial to each patient. There are some trials that do provide, particularly phase 1 trials where you're there for days in a row getting blood sampling. Some trials will provide some support, but I can't say there are grants that specifically address that. I'm not aware of any. Yeah.
Like those were all the questions in the queue. I'll make sure there wasn't anything that came in the chat. Those were it? Yeah.
Okay, so we're good?
Yeah, we are good. So
okay, thank you so much for inviting me today. It's my privilege I've been part of Debbie's Dreams organization for years. I had the privilege of working with Debbie Zellman for many years. She was a giant. She was a hero. And she is one of the people I've most admired in my entire life. Debbie's Dream is a tremendous organization. It's advocacy. I go to Advocacy Day every year if I can. I'm not sure if I was in that most recent picture. You might have left me out. But I was there last year, and I encourage active participation and support of this really innovative and selfless organization. Thanks so much.
And thank you, Dr. Ilson, for everything that you do for our organization and our patients and all the research that you do just to help everybody. We really, really appreciate you.
Okay, thanks so much.
Thank you. And then before I end the program, just to show you some of these upcoming events, please visit the website to register for some of these events. We again thank today's speaker for taking his time out of his busy schedule. And we'd like to thank our generous sponsors, platinum sponsors Bristol Myers Squibb, Merck and Taiho, bronze sponsor Arcus Biosciences, silver sponsor Amgen, and copper sponsor Lilly. To view any of our recorded webinars, please visit our lecture library on the website, or you'll see it on YouTube. This concludes today's presentation. Again, thank you everybody for tuning in. Take good care.